Hello again. This is Christine, and welcome to another short educational presentation on fluoroscopic imaging. Today we're going to review how to perform both pediatric voiding cystourethograms as well as adult cystourethography in order to properly evaluate the lower urinary tract. By the end of this video, you should be familiar with the appropriate indications and contraindications of your pediatric or adult patient for this study. You should also be able to describe an overview of the steps of a voiding cystourethrogram, or for short, Vcug. This includes listing the equipment necessary and understanding the preparation for the study. Lastly, you should be able to describe the views necessary for a cystogram or Vcug, proper positioning of either your male or female patient during the examination, and know how to identify common pediatric fluoroscopy diagnosis for these studies. Common indications for a pediatric Vcug include, but are not limited to, febrile UTI, congenital anomalies of the urinary tract, dysuria, and hematuria. Oftentimes, the patient will have accompanying ultrasound exams for diagnosis of hydronephrosis, hydroureter, or bladder outlet obstruction, and these should be reviewed prior to the fluoroscopic Vcug. Surgical notes should be reviewed for postoperative evaluation of the urinary tract. Indications for an adult cystogram or Vcug include indications of a pediatric Vcug, as well as bladder morphology, diverticula, suspected bladder rupture or fistula, post-op evaluation, obstruction, neoplasm, and evaluation of post-void residual volume. A Vcug examination is recommended in patients with the following ultrasonographic findings: bilateral high-grade hydronephrosis, duplicate kidneys with hydronephrosis, ureterocele, ureteral dilatation, and abnormal bladders. This is because the likelihood of vesicoureteral reflux is much higher. When infants who are diagnosed with prenatal hydronephrosis become symptomatic with UTI, further evaluation with a Vcug exam should be considered. Both adult and pediatric contraindications include recent bladder surgery, active urinary tract infection, and possible urethral injury. If urethral injury is suspected, a retrograde urethrogram should be performed prior to voiding cystourethography. In this examination, the patient is aseptically catheterized per department protocols, either by a registered nurse, a physician, or a physician extender. A Vcug may also be performed through an existing suprapubic catheter. Generally, no patient preparation is needed. Risks are minimal, as very few patients have allergic reactions to intravesical contrast. If a patient has had an anaphylactic reaction to intravenous contrast in the past, allergy prophylaxis should be considered. Latex precautions should also be observed, especially in those children with known latex allergies, multiple surgeries, or those with a diagnosis of myomeningocele. Materials include about 500 cc's of 8% water-soluble uroradiologic contrast like Cystoconray 2 or gastrographin dilute. This is secured on an IV pole. A 4 to 8 French Foley catheter is sufficient for most young pediatric patients. A 4 or 5 French catheter is preferred in premature or extremely small infants, or in cases of a urethral stricture. Basically, it's important to select a catheter appropriate for the patient's urethral anatomy. A catheter larger than 8 French may be used in adolescents and adults. You'll also need plastic tubing with a flow control device, an 18-gauge needle to allow contrast flow, and a luer to catheter adapter is needed to connect the contrast to the catheter. In males, to diminish sensation or pain, a topical anesthetic of 2% viscous lidocaine gel may be instilled retrograde into the urethra with aseptic technique. Anesthetic gel may be applied externally in both males and females. In order to avoid intravesical looping and knotting of the catheter, which may require invasive retrieval, excessive catheter length should not be inserted into the bladder. In uncircumcised males, if the foreskin is retracted at catheterization, It should be repositioned over the glands immediately following catheterization in order to avoid secondary paraphimosis. Catheters may be secured by using tape or by filling the attached balloon to the appropriate volume. For balloon catheters, the syringe used to inflate the balloon should be retained to deflate the balloon prior to voiding. For catheters without balloons, in girls, the catheter may be secured in place with tape to the perineum or to the thigh. In boys, once the catheter is inserted, a strip of tape may be placed on the catheter extending longitudinally along the dorsum of the penis to the symphysis. Circumferential placement of tape around the penis is discouraged. After catheter placement, the bladder should be drained prior to installation of contrast media, and a sterile urine specimen may be retained for culture if clinically indicated. If a recent abdominal image is not available, a preliminary abdominal image may be obtained and reviewed before instilling contrast media in order to detect findings that would affect the performance of the study, such as contrast in the GI tract, opaque calculi, and skeletal anomalies. Selective use of a lateral image may be helpful to evaluate the sacrum if there is a concern for sacral anomalies. We have a professional and ethical responsibility to keep ALARA in mind, and in many cases, fluoroscopic image capture is sufficient. However, a digitally acquired spot image or radiograph may be preferable in specific clinical situations needing superior spatial resolution. Even though VCUGs are one of the most commonly performed fluoroscopic investigations in pediatric radiology, there are also uncomfortable exams that can cause high levels of anxiety and stress. Since studies have shown that a child's distress and anxiety is increased when the patient is anxious or upset, but also reduced when the accompanying parent is calm, you should make a solid effort to explain the procedure to the parent to reduce their anxiety and therefore the child's distress. Make sure you explain the examination in detail to the parent to let them know what to expect. I encouraged at least one parent to stay in the room to help the child cope, to praise them, to talk them through the procedure, and to assist with the use of distraction techniques. Distraction techniques such as toys, videos, and books have shown to reduce stress and help the child cope with the examination. Contrast medium should be instilled via the gravity drip method and not by hand injection. This prevents the introduction of contrast medium under pressure and is less likely to cause transmucosal contrast medium absorption and consequential contrast reactions. The height of the bottle controls the infusion pressure, so a height of about 3 feet above the table height is typically sufficient. One of the main reasons for performing the VCUG is to detect vesicoureteral reflux, since vesicoureteral reflux in conjunction with UTIs can lead to significant morbidity with regard to impaired renal function and hypertension later in life. This justifies an active search for vesicoureteral reflux, especially in children under 5 years of age. Vesicoureteral reflux is graded according to severity from normal to grade 5, with grade 5 being the most severe, as noted on the prior slides. Before beginning the examination, it's important to note that pulse fluoroscopy, last image hold, and fluoroscopic image capture reduce radiation dose and should be used when available. Some departments also use video recording of the examination for later review. Fluoroscopy time should be monitored and minimized. The use of anti-scatter grids should be limited to older patients, generally patients weighing more than 40 to 50 pounds, or when the body part examined is greater than 12 centimeters in thickness. The examination should be collimated to the region of interest to limit dose. The room lighting should be dimmed in order to view the monitors adequately without having to increase technical factors. The patient is placed supine on the fluoroscopy table, and the image intensifier or flat panel detector is brought close to the patient to reduce the dose to the patient, you, the technologists, and the parents. Once the contrast begins to fill the bladder, intermittently screen the bladder fluoroscopically as the bladder begins to fill to confirm the correct catheter placement, as well as examine for ureteroseals, which may become obscured as the bladder fills with contrast medium. I usually speak with both the parent and the child during this time to ease tension and to encourage parent interaction. I may keep a last image capture of the filling phase if pathology is seen. A full bladder can be calculated using this formula. Once the bladder is filled, take a spot image to document the bladder at capacity. Depending on your supervising radiologist, some prefer oblique full bladder views. For pediatric patients, I usually have the technologist helping position at the foot of the bed and a parent helping guide the upper half of the baby or child. You can also use a dedicated fluoroscopy immobilization device to help position your patient. For adult patients, or if the patient is toilet trained, they are asked to hold the contrast in place until the bladder is full. Images are taken of the bladder in AP and both oblique positions. In the LPO position, image the right ureterovesical junction, and if reflux is seen, image the right ureter and kidney. In the RPO position, image the left ureterovesical junction, and if vesicoureteral reflux is seen, image the left ureter and kidney. If the exam is a cystogram, have the patient void in the restroom and obtain a post-void image to include the bladder and kidneys. For voiding studies, older males may be able to void more easily if the fluoroscopic table is tilted to 30 to 45 degrees, or if they're able to stand. The patient is instructed to void or urinate while under fluoroscopic observation. If the patient is an infant or baby, they are closely monitored visually and fluoroscopically during both the filling and voiding phases. The entire urethra should be demonstrated during the voiding phase. To image the urethra, boys should be positioned obliquely during voiding, with slight offset of the hips such that they are not superimposed. The female urethra is generally imaged in the frontal position, and catheter removal is not necessary for optimal views. Spot images of the kidneys immediately after voiding should be obtained to document the presence and grade of reflux, or its absence. A bladder view following voiding should be also obtained to assess the degree of bladder emptying. In cyclical studies, the following views should be obtained with each filling: a voiding urethra view and a renal and bladder view following voiding. Obtaining a second voiding cycle has been shown to increase the detection of vesicoureteral reflux with each filling. Keep in mind, however, there's a significant increase in dose to the patient with each cycle. Assessment of the study should include the following: bladder contour, location, capacity, and residual volume, bladder lumen and filling defects such as ureteroseals, clot, or other masses, the presence or absence of vesicoureteral reflux, the site insertion of ureters when visualized by reflux, grade of greatest reflux and at what point in the examination it occurred, the appearance of the entire urethra, and the presence or absence of extravasation or evidence of fistula. After reviewing the images and discussing the procedure with the radiologist, the patient is free to go without any special post-procedure care. Dictate findings of the study after reviewing the images with the radiologist. Thank you for watching this presentation on cystography and voiding cystourethropy.